Hello guys and welcome back to our channel CMS Prep. Today in this video we are going to be discussing endocrine surgery and all the questions that have been asked from it in the past 15 years in UPSC CMS. So let us start. First of all, what is the trend? As you can see guys, the questions are ranging from 1 to 2 in between, and in between they are absent also. So you can guess that approximately 1 to 2 questions will be asked from this chapter. And what are the topics that are being asked in this chapter? So questions are asked from thyroglossal cyst, parathyroid gland, papillary thyroid cancer carries the most weightage, as max 5 questions have been asked from this. Other types of cancer like medullary cancer or anaplastic or follicular cancer, thyrotoxicosis, 2 questions have been asked from this, and there are some miscellaneous topics from which 2 questions have been asked. So in total 19 questions have been asked in the previous 16 year, and you can easily expect 1 to 2 questions from this topic. So let us begin our discussion. The most common site for thyroglossal cyst is, so what is thyroglossal cyst? It is a remnant of thyroglossal duct in which cystic swelling takes place. So the most common site for thyroglossal cyst is subhyoid. It is a fact based question. Question number 2. Which of the following statement regarding thyroglossal duct are correct? It is situated in the midline of neck. Yes, it is correct. It moves upward on swelling but not on trunk protrusion. It moves upward on swelling but not on trunk protrusion. Yes, this is correct option. A thyroglossal duct cyst will typically move upward during swelling because of the movement of the hyoid bone, but it does not move with trunk protrusion, which help it to differentiate with other swellings in the neck. It is treated with cyst trunk operation. Yes, this is the correct option. Cyst trunk operation is en bloc removal of the thyroglossal cyst along with the affected hyoid bone. It may be the only functioning thyroid tissue in the body. This is incorrect because the thyroglossal duct remnant is generally non-functional. However, in rare cases, functioning thyroid may be present in the duct remnant, but this is not typical. Hence, the option is incorrect. The correct option is option number 1, 2, and I. A midline neck swelling just below the hyoid bone and managed by cyst trunk operation leads to post-operative need for thyroxine replacement. The most likely diagnosis is, the correct option is thyroglossal cyst with only functioning thyroid tissue. Yes, this is the correct option, because if other thyroid tissue had been active, so there would be no need of thyroxine. So cyst trunk operation denotes that it was a thyroglossal duct cyst, but along with that it was the only functioning thyroid tissue. Therefore, there is the need of post-operative thyroxine replacement. Hence, this is the. Now let us see question related to parathyroid gland. The most common site for parathyroid adenoma is, so the most common site for parathyroid adenoma is the inferior parathyroid lobe. Parathyroid adenoma are most commonly found in the inferior parathyroid gland. These glands develop from the third parapharyngeal pouch, which makes them more variable in location and prone to ectopic positions. Why others are incorrect? Intrathyroid, rare, though adenomas can be found within the thyroid tissue. So it is a rare type. In the superior parathyroid lobe, less common, as the superior parathyroid are less variable in position. And mediastinal. So mediastinal is possible but rare. Some parathyroid tissue may migrate to the mediastinum, but it is not the common adenoma site. So the most common site for adenoma of parathyroid gland is the inferior parathyroid lobe. Which of the following strongly suggests the diagnosis of primary hyperparathyroidism? Serum acid phosphatase above 120 international unit per liter. Not relevant to primary hyperparathyroidism. It is typically associated with prostate cancer. Urinary calcium below 100 mg per day. In primary hyperparathyroidism, urinary calcium is often elevated due to high serum calcium. So this is not the correct option. Serum alkaline phosphatase above 120 international unit per liter. It is may be elevated in bone disease, but it is non-specific and non-diagnostic of primary hyperthyroidism alone. So the correct option is serum calcium above 11 milligram per deciliter. Elevated serum calcium is a key indicator of primary hyperparathyroidism, as excessive parathyroid hormone causes increased calcium from bone, absorption from gut and reabsorption from kidney. Hence, this is elevated in primary hyperparathyroidism. The commonest cause of primary hyperparathyroidism is parathyroid adenoma. This is the correct option. It is also a fact-based question. All the following can result in hyperparathyroidism, but the most common cause is primary parathyroid adenoma. This is the most common cause of primary hyperparathyroidism, accounting for about 80 to 85% of the cases are due to parathyroid adenoma. Idiopathic parathyroid hyperplasia accounts for 10 to 15% of the cases. Familial hyperparathyroidism is rare, associated with genetic syndrome like MEN1 and MEN2A, and primary parathyroid carcinoma is extremely rare, representing only 1% of the cases. Question number 7. Which of the following statement regarding papillary thyroid cancer are correct? It is the most common malignant tumor of the thyroid gland. Yes, it is correct. It is more common in young female. Yes, it is correct. It has propensity for hematogenous spread. No, this is incorrect. It has propensity for lymphatic spread. Papillary thyroid carcinoma typically spread via lymphatic channel, not hematogenously. Hematogenous spread is most common seen in follicular carcinoma, and distance metastases are uncommon. Correct. While parathyroid carcinoma can metastasize, distant metastases such as to the lungs and bone are relatively uncommon, and the prognosis is generally favorable. Hence, the correct option is option number 1, 2 and 4. Question number 8. Serum thyroglobulin is an important tumor marker for. So, in medullary carcinoma thyroid, the tumor marker is calcitonin or CEA. In papillary carcinoma thyroid, it is thyroglobulin. Anaplastic carcinoma of thyroid does not produce thyroglobulin, and thyroid lymphoma of the thyroid is not associated with thyroglobulin production, as it arises from lymphoid tissue, not thyroid tissue. So the correct option is papillary carcinoma of thyroid. A 25-year-old female with previous history of neck irradiation presents with thyroid swelling for last 6 months. The patient is clinically euthyroid. On examination, the right lobe of the thyroid gland is enlarged with presence of ipsilateral cervical lymphadenopathy. The most probable clinical diagnosis is, so the most important point here is history of neck irradiation. So the history of neck irradiation points towards papillary carcinoma thyroid. So this is the most likely diagnosis, especially in patient with history of neck irradiation. The presence of thyroid nodule with cervical lymphadenopathy is typical of this cancer. So medullary carcinoma, why this is not the answer? Because often associated with genetic condition like MEN2 and does not have the same association with radiation exposure. Lymphoma, while lymphoma can present with thyroid mass, it typically presents with more systemic features like fever, weight loss and night sweat, and it is less likely to be associated with solitary thyroid nodule. So this case is a case of solitary thyroid nodule like presentation, which can point us towards medullary or papillary. So in medullary, there must be presence of other symptom which point towards the MEN syndrome, but it is not the case here. Hence, papillary carcinoma thyroid is the correct option. And why not follicular carcinoma of thyroid? So follicular carcinoma of thyroid also occurs in the thyroid, but it is not strongly associated with radiation as it is associated with papillary carcinoma thyroid. This more develops in long standing goiter. So if a patient has long standing goiter, it can develop into follicular carcinoma, and it presents with a cold nodule, and it is not likely to involve lymph nodes in the early stages. It generally spreads via blood to the skull bones. So hence the correct answer is papillary carcinoma thyroid. Next question, most common neoplasm of the thyroid gland is, again a fact based question. The correct answer is papillary carcinoma. Surgical treatment for a 40-year-old lady 3 cm and 3 cm by 3 cm papillary carcinoma thyroid with level 3 enlarged lymph node is total thyroidectomy with excision of involved lymph node, total thyroidectomy with radical neck dissection, total thyroidectomy with functional neck dissection, total thyroidectomy with post-operative radioiodine ablation. So the correct option, functional neck dissection, is also known as modified radical neck dissection. So the correct option is option number C. For papillary thyroid carcinoma with lymph node involvement, especially level 3, the preferred approach is total thyroidectomy combined with a functional or modified neck dissection. This procedure involves the removal of involved lymph node while preserving non-lymphatic structures like nerve and muscles to reduce the morbidity. Why others are less suitable? So the option number 1, total thyroidectomy with excision of involved lymph node. This is a selective approach might leave behind microscopic disease, as level specific lymphadenectomy alone may not be adequate for papillary thyroid carcinoma. Total thyroidectomy with radical neck dissection is more extensive, removing additional structure like sternocleidomastoid, internal jugular vein and accessory nerve, and is generally reserved for extensive or aggressive disease, which is typical for a 3 cm papillary carcinoma. Total thyroidectomy with post-operative radioablation. While radioiodine ablation is often used post-surgery, it is not sufficient alone for initial management where there is nodal involvement. So the correct option is option number C. Medical management of thyrotoxic crisis includes all of the following except IV fluids, yes it has to be given, IV propranolol, yes it has to be given, and IV hydrocortisone, it is also to be given. But IV antibiotics carry no role in thyrotoxic crisis because it is not typically caused due to infection, so antibiotics are not routine part of its management unless there is an underlying infection. So focus on controlling the thyroid hormone excess and stabilizing the patient. Why others are correct? IV fluid, yes it is important to correct dehydration and maintain electrolyte balance, as thyroid crisis can cause significant fluid loss. IV propranolol, a beta blocker like propranolol, is used to block the effect of excessive hormones on the heart, reducing symptoms like tachycardia. Hydrocortisone, steroid like hydrocortisone, reduce the conversion of T4 to the more active T3 and address the potential adrenal insufficiency which may occur in a thyroid issue. Treatment of choice for recurrent thyrotoxicosis after surgery is, the correct option is radioiodine. Radioactive iodine is the preferred treatment for recurrent thyrotoxicosis. It is effective in ablating the residual thyroid tissue or recurrent hyperfunctioning thyroid cell and avoids the risk associated with further surgery. So why other options are less suitable? Further surgery, this is incorrect because additional surgery increases the risk of complications such as damage to the nerves or hypoparathyroidism, and it is avoided unless absolutely necessary. Radioiodine followed by surgery. Surgery is usually avoided if radioiodine alone can achieve remission. Observe and follow up. Observation alone is not suitable for recurrent thyrotoxicosis due to the potential complication like untreated hyperthyroidism and cardiovascular risk. So the correct option is radioiodine ablation. Now let us see other questions from cancer. Serum calcitonin may be elevated in, so it is a one-liner. Serum calcitonin is elevated in medullary carcinoma of thyroid. Islet cell cancer involves increased production of insulin glucagon or somatostatin. Choriocarcinoma of the ovary produces HCG, and carcinoid tumor of the appendix produces serotonin and other peptides but not calcitonin. Hence the correct option is medullary carcinoma of thyroid. Fine needle aspiration cytology is not conclusive for which of the following cancer? So the option is follicular carcinoma of thyroid. See, in follicular carcinoma of thyroid you cannot FNAC cannot differentiate between adenoma and carcinoma. So for this we have to do frozen section. After lobectomy we have to send it to the lab, and in the lab it is confirmed that whether it is carcinoma or adenoma. Hence FNAC is not conclusive in follicular carcinoma of thyroid. A 60-year-old lady presents with recent onset increase in long standing thyroid swelling in the front of the neck. The swelling, which was small, had been present in the last 30 years but has now increased to more than twice the size in last 2 months. On examination the swelling is firm to hard in consistency and moves with deglutition. What is the most likely cause of the clinical presentation? Cystic degeneration, hemorrhage, malignant transformation or myxomatous transformation? So the correct answer is malignant transformation, as all of the following features points towards it. Why? Let us see. There is rapid increase in size in the context to a firm and hard consistency and mobility with deglutition, which suggests that the swelling is thyroid in origin. Thyroid nodule or cyst that are present for year but suddenly enlarge may indicate the development of thyroid cancer such as papillary thyroid carcinoma or follicular carcinoma. Why others are less likely? Cystic degeneration. While cystic degeneration can cause some enlargement of thyroid nodule, it generally leads to a soft or fluctuant consistency, not firm and nodular one. Hemorrhage in thyroid can cause sudden enlargement but cause a typically tender swelling and not firm and hard swelling. And myxomatous transformation. This refers to the formation of a gelatinous soft consistency in certain benign tumor, but it is less likely to explain the firmness and rapid increase in size described in this case. So the sudden increase in size, firm consistency and a history of long-standing swelling points more strongly towards a malignant transformation. Hence, this is the correct option. Which of the following is not correct regarding MEN1 syndrome? So MEN1 syndrome involves the pituitary, pancreas and parathyroid, triple P. So let us check. It involves the parathyroid gland, correct. It involves the pancreas, correct. It involves the pituitary gland. Option D is incorrect. It does not involve the pineal gland. Now question number 18. Which is the best and the most sensitive investigation for hypothyroidism? So this is a very easy question. The best and the most sensitive investigation for hypothyroidism is TSH level. It is the most sensitive and earlier marker for hypothyroidism. When thyroid level drop, the pituitary releases more TSH to stimulate the thyroid, which lead to elevated TSH. It is usually the first test to diagnose hypothyroidism. TRH level is not commonly used to diagnose hypothyroidism. T3 and T4 level are important. They may be normal, but they are not used or they are not sensitive because they may be normal in the early stage of hypothyroidism and may not reflect the condition as sensitively as TSH. TSH changes before T3 and T4 in hypothyroidism. Radioactive iodine uptake. This test is more apt for assessing thyroid condition in diseases like hyperthyroidism and particularly in grave disease, not in hypothyroidism. It measures the thyroid ability to take up the iodine, which is not a useful marker for hypothyroidism. Therefore, radioactive iodine uptake is not the correct answer. T3 and T4 may be normal, so they are not sensitive, and TRH level is not generally used for diagnosing hypothyroidism, so the correct answer is TSH level. Question number 19. A few days following viral fever, a 50-year-old female presents with pain in neck, fever, malaise and firm enlargement of both lobes of thyroid. On investigation, thyroid antibody were normal and serum T4 was high. So what is the probable diagnosis? Autoimmune thyroiditis, lymphoma of the thyroid, granulomatous thyroiditis or Reeder's thyroiditis. So let us see the option. Autoimmune thyroiditis, this typically presents with gradual onset of symptom and usually shows elevated thyroid antibodies, example anti-TPO antibodies, which are normal in this case. Lymphoma of thyroid most likely to present with a painless, firm and rapidly enlarging thyroid mass, but not typically associated with viral infection or high T4 level. Reeder's thyroiditis is a rare condition associated with fibrosing thyroiditis that causes hard and fixed thyroid mass and not associated with viral infection or elevated T4. So the correct option is granulomatous thyroiditis. Let us discuss. It is also known as decuvariance thyroiditis. This condition typically follow viral infection presenting with pain in the neck, fever, malaise and thyroid enlargement. It is associated with elevated serum T4 due to the release of stored thyroid hormones. Thyroid antibodies are usually normal in this condition, distinguishing it from autoimmune thyroid. So granulomatous thyroiditis, also known as decuvariance thyroiditis, is usually after a viral fever and presents with pain in the neck and fever, malaise and firm enlargement of both lobes of thyroid along with normal antibodies. If there is thyroid antibodies, then it is a case of autoimmune thyroiditis. So with this we have covered all the 19 questions asked from thyroid in the previous year from 2009 to 2024. You can find the PDF in our Telegram group, CMS Prep. Till then, please like, comment, share, follow and subscribe to our channel. More videos coming soon. Thank you.